Okay, guys, this is your promoting asepsis and your infection control, which is your chapters 23 from your fundamentals book. So these are going to be your key terms that'll be good for you to know. You can find these in your book or in your Tabler's dictionary. Your learning objectives are also straight from your book. And we have infection. So what's an infection? An infection is an invasion of a pathogen which causes disease and illness. Why nurses need to know about an infectious process is because the goals are to prevent and control. We want to protect our patients. We want to meet professional standards and guidelines. We want to protect ourselves from disease, and it's going to help lower the cost of healthcare. Currently, healthcare or hospital or nosocomial infections are the 10th leading cause of death. And it's actually probably higher. It's estimated that 1 in 25 patients has a hospital-associated infection. Many of these are serious infections, and they can easily be transmitted from one patient to another. These infections fall into the facility to cover the cost, not the patient, and not the patient's insurance or healthcare coverage. So first, we're going to talk about the spread of the infection, and there are 6 links. And if we can break the link, then hopefully the person would not get the infection. So we're going to start with the normal flora and how the infectious agents can get it. So the first link, right, we have our flora, and flora are sometimes transient flora. They're normal microbes that a person picks up by coming in contact with objects or another person. So when we touch a soil dressing, we can remove these easily with our hand washing. Resident flora lives deep in skin layers where they live and multiply harmlessly. They're permanent inhabitants of our skin and cannot usually be removed with routine hand washing. They are not usually harmful unless they are entered in the tissues through an open wound or if our patient becomes vulnerable. And then we have pathogens. These are microorganisms that are capable of causing disease. The largest group of pathogenic microorganisms are bacteria, viruses, and fungi, which include yeast and mold. Less common pathogens are your protozoans and your helminthias, which are worms. These are infectious protein particles that can cause certain neurological diseases. So then we have our reservoir, right? That's your second line. And your reservoir is the source of the infection, a place where the pathogen survives and multiplies. This is human body is the most common reservoir for pathogens. However, animals, insects, and humans and other living reservoirs. Also, we have non-living reservoirs that include soil, water, food, and environmental services. Our portal of exit, this is your third link. Your portal of exit, in the case of human or animal reservoirs, the most frequent portal of exit is through body fluids. This includes blood, mucus, saliva, breast milk, urine, feces, vomit, semen, and other secretions. Our mode of transmission is our fourth, and we have direct contact. This occurs between 2 people and usually involves touching, kissing, or sexual intercourse. Indirect contact involves contact with a fomite, or a contaminated object that transfers the pathogen. We have droplet transmission, and this is an infectious path through the pathogen, travel in water droplets expelled as the infected person exhales, coughs, sneezes, or talks. And they also occur during suctioning or oral care. The usual method of transmission is the droplet is inhaled or entered the eye of a susceptible person. Airborne pathogens can travel through heating and airing conditioning systems to infect large numbers of people. Sweeping a floor, shaking out contaminated bed linens can stir up the airborne microorganisms and launch them on air currents. Imagine a flying magic carpet of pathogens. The agents of the measles, tuberculosis, and even COVID, and many fungal, are commonly transmitted in this manner. And then we have vector. So a vector is an organism that carries a pathogen to a susceptible host. The mosquito is a common vector for disease, including malaria, yellow fever, and West Nile. Ticks commonly are associated with Lyme's disease and Rocky Mountain. Fleas and mites in some animals can also be vectors of other pathogens. So the fifth, is your portal of entry. Pathogens can enter the body through various portals of entry. Normal body openings, such as the conjunctiva of the eye, the nares, which are your nostrils, the mouth, the urethra, the vaginal and anus, are potential portals of entry, as are abnormal openings, such as cuts, scrapes, and surgical incisions. Vectors, as a mosquito, create portals of entry when they bite through the skin. In healthcare setting, common portals of entry include surgical sites and insertional sites for tubes and needles. Our sixth is our susceptible host. So a person who is at risk for an infection because of inadequate defense against the invading pathogen. Various factors can increase susceptibility to an infection. Among them are age, the very young or the very old, those with compromised immune systems, as in those receiving immune suppression for organ transplant or treatment of cancer or chronic illness, and your immune deficiency conditions like HIV and leukemia. Our stages of infection. So we have our incubation. In this stage, the person does not suspect that he or she has been infected, but they are often capable of infecting others. This stage may last only a day, as in with influenza, or longer with things like tuberculosis and HIV, where you can go 7 months, several months, or even years without realizing that you're ill. Your prodromal phase, as a person is infected with a cold virus, may experience a mild throat irritation. They do not have all of the symptoms of the infection yet. Illness. This is when the patient's immune defense and medical treatments, if any, are ineffective. This stage can end in death of the patient. This stage is when the patient is going to have all the signs and symptoms. Decline. During this stage, the patient's immune defense, along with the other medical therapies, successfully reduce the number of pathogenic microbes. As a result, signs and symptoms of the infection begin to fade. Convalescence. This is characterized by tissue repair and return to health. As the remaining number of microorganisms approach zero, convalescence may require only a day or two, but for severe infections, it can be a year or more. Some illnesses, the patient will never return to health. Some patients will continue to bounce between illness and decline. Classification and infections. Classifications of your infections. So we can have a local infection, and your local infection are those that cause harm to a limited region in the body, such as an upper respiratory infection that will just involve your lungs, urinary tract infection, which just affects your urethra, or you could have a simple infection to a wound. And then we have a systemic infection. And this occurs when the pathogen invaded the blood or the lymph and spread throughout the entire body. We commonly hear it as bacteremia, and this is when the bacteria is in the blood, or septicemia, which is a entire systematic infection spread via the blood. So this would be like your sepsis alerts, your patients that have an extreme infection And then we have classifications of infection by duration. So is an acute infection, did it have a rapid onset, but it only lasts a short time like the common cold? Is it a chronic infection like an abscess that develops slowly and lasts for weeks or months or years? Some chronic infections have relapsing fevers and they reoccur after periods of remission. And then we kind of latent infection that cause no symptoms for periods of times over even decades, like tuberculosis or HIV. So our primary and secondary, your primary infection is the first infection that occurs in the patient. And a secondary infection is one that follows a primary infection, especially in the immune-compromised patient. So a frail client infected with pneumonia may develop herpes zoster related to the stress of the illness. And then we have exogenous and endogenous. Your exo are related to healthcare. So the pathogen is acquired from the healthcare environment. Endogenous healthcare related is the pathogen arrives from the patient's normal flora from the treatment. So the most common example of that would be a yeast infection that develops from antibiotics. So the primary infection here is the HIV, and it causes the patient to become immune compromised, and then they develop the infection of the complete. So healthcare related infections. Healthcare related infections, healthcare associated infections, or sometimes also referred to as nosocomial infections. And this refers more specifically to hospital-acquired infections, things that were caused because the patient was in the hospital. Healthcare associated infections are the leading complications of hospital care and one of 10 leading causes of death. As I said before, approximately 1 of every 25 patients has had at least one healthcare associated infection. These are the infections that the hospitals will not receive reimbursements for. And these are the things that we want to prevent from happening. And your examples of that would be your central line infections, your urinary catheter infections, pneumonia for patients that are on vent, and surgical site infections for patients that have had surgeries. So emerging pathogens and disease are things that we as nurses need to be aware of. There are epidemic, which is an outbreak of a disease that suddenly affects a large group of people in a geographic region, which can be a city or a state, or in a defined population, like children or healthcare workers. Pandemic is an exceptionally widespread epidemic. This is one that affects a large number of people in an entire country or worldwide. Examples of our pandemics would be what we just went through with COVID. With emerging infectious disease, although there are various definitions, you can think of emerging infections as newly identified. So this is an unrecognized microorganism, or it can be a disease occurring in a new geographic area. So Ebola is originated in Western Africa. However, when it came over to the United States, that would have fit into that. Microorganisms in animals or insects that extended their host range. So we had bird flu, which normally did not affect humans, and then it did. The avian flu, which is now considered H1N1. No, I'm sorry, H1N1 is from the swines. And Zika is from the mosquitoes. Microorganisms that evolved to become more virulent. So this would be a strain of E. coli, which now causes severe illness. known diseases that dramatically increase in incidence as a result of a fail or poor compliance with a public health record. So when we had an outbreak of mumps because water treatment issues, or I'm sorry, we had an outbreak of mumps because of people that were not vaccinated against it. And we also had an outbreak of cholera because of water treatment issues. And lastly, we're going to talk about our multi-resistant organisms. These are antibiotic resistance. They are challenging to treat in patients. They can cause severe infections to disease, and they're becoming increasingly frequent in our healthcare populations, evidenced by MRSA, VRE, and the list goes on. So what's your body's defense against all this, right? We have primary, secondary, and tertiary defense systems. So our primary line of defense is going to be those things on our body that prevent us from getting sick. So first and foremost, we have our intact skin. The surface of the intact, healthy skin is tough and it's resilient, and it prevents entry of many pathogens into our body. Our skin has normal flora on it that inhibits other organisms from growing when they land on our skin. Then we have our mucous membranes, right? These mucous membranes are our nares, our trachea, our bronchi. It's everything that mucus covers, and this mucus will trap the pathogen and then it can be expelled. So your nose has little hairs that filter. And then once these microorganisms are noticed, we're going to cough, we're going to sneeze, and we're going to forcefully expel the organisms from the trap. Then we have tears. So your tears come from your glands, and they contain lysosomes, which is an antimicrobial enzyme. So tears help the body wash infected organisms from our eyes. We have our normal flora in our GI tract. Many pathogens that reach the stomach are destroyed in its acidic environment. Those that successfully enter the small intestine face the antimicrobial action of bile. Simple peristalsis, as well as diarrhea and vomiting, are other first-line defense mechanisms from pathogens that invade the GI tract. In addition, normal flora in the intestines secrete antibacterial substances. And then we have the normal flora in the urinary tract. And the genitourinary tract is protected with mucous membranes as well. The epithelial cells lining the urethra and the anus secrete mucus, which adheres to pathogens to promote their excretion through urine and stool. Urine is highly acidic and contains lyses. Mucous membranes lining the vagina also keep pathogens from establishing colonies there. In addition, the high acidity and normal flora in the vaginal area keep pathogens in check. We have our secondary line of defense against. So think about your primary is your gatekeepers, and then your secondary are when it gets through past the gatekeepers, and now the body begins to release things to combat it. So one of the primary things that we're going to have for secondary defense is our phagocytes. And the process by which phagocytes, which are specialized white blood cells, engulf and destroy pathogens directly, is called phagocytosis. Phagocytic white blood cells include neutrophils, monocytes, and eosinophils. We have our cascade, and this complement cascade is a process by which a set of blood proteins called complement trigger the release of chemicals that attack the cell membranes of the pathogens, causing them to rupture. Complement also signals basophils, which are part of the white blood cells, to release histamines, which promotes inflammation. The inflammation is a process that begins when the histamine and other chemicals are released, either from damaged cells or from basophils being activated. With the inflammation, blood vessels dilate and become more permeable, which increases the flow of phagocytes, antimicrobial chemicals, oxygens, and nutrients to the affected area. The classic signs and symptoms of inflammation are localized warmth, erythema, which develops as blood flow is increased. And finally, we have fever. So fever is a rise in your body's temperature that increases metabolism. It inhibits multiplication of the pathogens and triggers specific immune responses. Believing that low-grade fevers are a necessary natural defense mechanisms, many clinicians do not treat a fever unless it's greater than 102. And then we have our tertiary line of defenses against the infection. So we can have active, passive, and specific immunity. So types of immunity, we have our natural immunity, right? So this is a person that becomes ill with an infection. The body produces its own antibodies to fight the disease causing organism and protect from infection in the future. So influenza. Then we have our artificial active immunity. An immune response occurs when the body is exposed to weakened or dead pathogens in a vaccine. The body then makes T cells or antibodies to keep from actually developing the illness, like tetanus and measles vaccine. This type of immunity offers long-lasting or even lifetime protection. Our natural passive immunity. This is immunity results natural antibodies are passed from one body to another, such as a mother to baby through placenta or through breastfeeding. Our artificial passive immunity is when we receive serum from another person or animal that has already produced the antibodies against the pathogen. So this would be the serum treatment for rabies or botulism. We have our cell immunity. So your cellular cell immunity immune response acts directly to destroy the pathogen. So against a virus, a fungi, a protozoa, a cancer. Without using antibodies, but rather activating phagocytes and T and B cells. 4 types of T cells play a role in fighting an infection. The first one is our T cell cytotoxic killer T cells. They directly attack and kill body cells infected with the pathogens. The helper T cells play a supportive role in cell-mediated responses by secreting interleukin, which attacks infection-fighting white blood cells. Our memory T cells are the first time an antigen invades the body. T cells form that respond to a specific antigen with susceptible infections. The T cells, or memory cells, are able to increase the speed and the amount of the T cell response. And then we have suppressor T cells that are thought to stop immune response when the infection has been contained. We also have humoral immunity. The humoral immune response, or the antibody-mediated response, as it's sometimes called, protects the body by circulating antibodies to fight against pathogens. The body's defense system acts by producing specialized white blood cells, leukocytes, to seek out and destroy invaders by any of the following methods. So we have phagocytosis, and phagocytosis is your immunoglobulins, which we'll talk about on the next slide, which are specialized proteins in the body's immune system that function like antibodies. We have neutralization, which is by binding to a pathogen's attachment sites. Antibodies disable the pathogen by adhering to invading body cells. Thus, although they are not destroying the pathogen, they inhibit its effectiveness. Agglutination, which is antibodies have attached have two attachment sites. Therefore, each antibody can attach to two pathogen cells in a population. This characteristic causes the pathogen to clump together, reducing their activity and increasing their likelihood that the group will be detected and destroyed by the leukocytes. And then we have activation of complement and inflammation, which are antibodies trigger the complement cascade and stimulate the release of inflammatory chemicals to destroy the antigen. So our different immunoglobulins, right? IgM is your first. This is the first antibody to appear when an antigen or a pathogen is encountered. It is also involved in agglutination with incompatible blood types. Our IgG is the most common immunoglobulin in the body. It takes at least 10 days for IgG to be produced in response to an initial infection. IgG is the only immunoglobulin that can cross the placental to provide temporary immunity to the fetus. And then we have IgE, which is associated with our allergic responses. So if you have somebody who has anaphylaxis, they have an IgE reaction. We have an IgA, and this is found in the mucous membranes in the intestines, respiratory and urinary tracts, your saliva, tears, and breast milk. IgA provides additional immune protection by secreting around the body openings. And then IgD, which forms on the surface of B cells and traps the potential pathogen to prevent it from replicating and causing disease. So now we move into the factors that increase our risk for infection. So we have our developmental stage, right? The very young that do not have a fully mature immune system. Children frequently begin to have more infections when they start interacting with people outside their family. So when they start daycare, and with this exposure, the body's natural defense system turns on to protect from infections. This natural process is known as active immunity. And when we're older, we have more chronic illnesses and more chronic disease that weaken our immune system. And we only have so many reserves for our immune system. So if it's always busy dealing with our chronic illnesses and our chronic diseases, we might not have the ability to fight off the infections. We can have a break in skin, whether it's caused by a surgical or skin breakdown, an insect bite, anything that can allow that portal of entry. We have smoking and substance abuse. So smoking interferes with our normal respiratory functioning, including the ability to move the chest wall, to cough, sneeze, or have a full air exchange. Chemicals in tobacco paralyze our cilia, thus secretion pools in the lower airways. This will create a good environment for bacterial growth. Although tobacco users are most profoundly affected by these changes, people exposed chronically to secondhand smoke, like former bartenders or children of smokers, can also be affected by these changes and therefore have an increased risk for infection. Multiple sex partners places us at a risk for increased sexually transmitted infections, as well as for surgical cancers. And then we have medications that inhibit or decrease our immune response. So common medications like nonsteroidal anti-inflammatory agents and regular steroids can actually decrease the immune response. As a side effect, some medications such as chemotherapeutic agents decrease production of white blood cells or cause cells produced to become abnormal. Even antibiotics can increase our risk for additional infections. Things that we can do to support Our host's defense is we need to make sure that they get adequate nutrition, right? We know that acute infection depletes the body's nutritional stores. Therefore, it's important to monitor and support client nutrition, including protein, vitamins, minerals, and water. Nutrients are required to replace lost stores, to maintain production of white blood cells, and to repair damaged tissue. Fever and increased mucus secretions, which are common defenses against infection, increase our water loss. Additional water is needed to supplement the lost fluid and to support the increased metabolic rate that occurs with fevers. Balanced hygiene. We need to encourage frequent hand washing as well as regular showering or bathing. This will decrease the bacteria count on the skin. However, be aware that overzealous cleaning diminishes the skin's natural oils and may lead to cracking of the skin. Rest and exercise. Rest and sleep renew the body and mind and conserve strength. Sleep needs vary, and there is no correct amount or pattern of sleep. However, sleep 6 to 9 hours per night is considered fully restorative for most people. Reducing stress. Whether physical or mental stress decreases the body's immune defense. Laughing, in contrast, increases oxygenation, promotes movement, and increases your overall immune response. Immunizations. Immunizations via vaccination can protect against several infectious diseases, like your measles, mumps, and other childhood diseases, pneumonia, influenza, smallpox, and shingles. Unfortunately, some pathogens, such as the virus that causes the common cold, mutates too rapidly for immunizations to be developed. We need to encourage clients to follow recommendations for immunizations. For most diseases, at least 85% of the population must be immunized in order to protect the entire population from the disease. Preventing infection, implementing medical asepsis. So medical asepsis refers to the procedure that decreases the potential for the spread of infections in the healthcare setting. Medical asepsis includes hand hygiene, environmental cleanliness, standard precautions, and protective isolation. Our hand hygiene is the single most important activity for preventing and controlling infection. The World Health Organization has chosen as the first global patient safety challenge the reduction of healthcare associated infections within the theme Clean Care is Safe Care. They have made hand hygiene the cornerstone strategy because it is simple, standardized, low cost, and based on solid scientific evidence. Maintaining a clean environment. We need to clean up our spills and our dirty surfaces promptly. We need to remove pathogens through chemical means of disinfecting. We need to follow the label directions on the disinfectant, allowing it to dry in the appropriate time, because that time that the jar has that it has to be on the surface is what they know that chemical needs to penetrate and kill the pathogens that they say it will. We need to remove clutter because of things can harbor and fester and grow in cluttered areas. And we need to consider supplies brought into the client's room as contaminated. We would not bring bandages out of the client's room to put back into clean supply or to use in another patient's room. It's contaminated and it stays with them. And that goes the same with the things that patients bring from their home. We wouldn't want to take something that a patient brings from their home and set it out at the desk where somebody else could touch it and contaminate and bring it to another. So now we're going over when we wash our hands, right? We wash our hands when you arrive on the unit, when you leave the unit, before and after you use the restroom, before and after you have contact with the patient, before and after you contact the patient's belongings, before gloving, after gloving, before and after touching your face, before and after eating, after touching a contaminated article, and when you see visible dirt on your hands. Nurses need to wash their hands constantly. And if you note somebody that's only washing their hands just when they exit the room, they're at a higher potential to spreading infections to other patients or to you. So our hand washing guidelines, what are they? You need to wash our hands for at least 15 seconds if we're in the non-surgical setting. If you're in the surgical setting, it should be a 2 to 6 minute scrub. We need to make sure that we remove all jewelry and clean beneath our nails. We need to use a bacterial cider solution or use water if hands are visibly soiled. We want to use warm water, not hot water, because hot water will crack our skins, increasing our risk for infection. We want to apply soap to wet the hands, use friction, rinse, and towel dry. And these are those steps again, right? We're going to push up our sleeves above our wrists. We're going to turn on the water. We're going to wet our hands and our arm surfaces. We're going to apply the soap and rub together and clean under our nails. We're going to rinse the soap off. We're going to dry our hands, and then we're going to turn the water off with a paper towel. So implementing the CDC guidelines for our transmission-based precautions. So standard precautions is that everybody could potentially have something, and we have then our different transmissions, and we're going to go over all of this. So it's standard precautions. This is considered a tier 1 precaution, and this first tier is protection to us, and we apply it to all of our patients. We must assume that every patient is potentially colonized or infected with an organism that could be passed to others in the healthcare setting. We will use hand hygiene, gloves, and gown, mask, and eye protection or face shield, depending on the expected exposure. We also want to use safe injection practices. Standard precautions do not completely protect against microorganisms spread by contact droplets or through air, which is why we have advanced. So this second tier is tier 2 precautions. And this we're going to use for a patient with a suspected infection that would be spread by direct contact. So your sources of this infection would be a draining wound, secretions. C. diff is a very common infection, which is the infected stool. The precautions we would take is we would want to give the patient a private room. We would want to use gloves and gowns. We would want to make sure that we dispose of all contaminated items in the room. And we want to make sure that we double bag linen and marking. Our droplet precautions are going to be pathogens that are spread through respiratory secretions. This is your more thicker stuff, and it's going to be through sneezing, coughing, and talking. Our protections and our precautions are going to be the same as those for contact, except now we're going to add a surgical mask and also wear eye protection if we're moving 3 feet into the patient. Our airborne precautions are pathogens that spread via air currents. This is transmission can be through the ventilation system, shaking up sheets, sweeping. These patients need to be in a special isolation room that has negative pressure, that the ventilation system is sucking the air out of the room and it's not putting it into the system with everything else. We need to wear that N95 mask with these patients. An example of this would be TB or COVID. We also have protective isolation. So protective isolation means that our patient is immune compromised or can be easily infected. So protective isolation, this is used for clients with low white blood cell counts, patients that are going under chemotherapy, patients with large wounds or weakened immune systems. We want to protect them. It usually will include following standard precautions. We want to place the patient in a private room. We may restrict visitors. We need to make sure we wear a mask, gown, and gloves when we're providing patient care. And we want to use special cleaning and disposing of patients' equipment and supplies. Some units, such as the neonatal intensive care units, burn units, labor and delivery, all place patients on protective isolation. All patients on isolation should be transported with appropriate precautions. So the patient might need to wear a mask. We would not put somebody who is respiratory compromised or a patient in a 95 mask, but we would make sure that they had a surgical mask on. We also need to make sure that we have dedicated equipment. Blood pressure cuffs, stethoscopes, and thermometers should all be left in the patient's room and not cleaned and brought into other patients' room routine. We also want to limit the ins and outs of the room. This does not mean that we do not go in to care for the patient, but it does mean that we want to make sure that we gather the appropriate things that we need, or we might want to implement a runner, meaning you, the nurse, are going to provide the air, and maybe your aide or tech is going to stand on the outside and get you additional supplies if you need. Implementing surgical asepsis. What does that include? So we have our surgical scrub. This is a modification of hand washing procedure described earlier. It traditionally involves an extended scrub of the hands using a sponge, nail cleaner, and a bacterial scrubbing agent. A newer method uses brushless scrub using a bacterial scrubbing agent. All methods require pre-wash before the surgical scrub. We have donning of surgical attire. Burn units, labor and delivery units, and other wards require surgical attire for caring for these patients. In each of these units, nurses care for patients that are increased risk for infection. They may need to have specific scrubs. They may put on hats, shoe coverings, hair nets, and things of that nature. So exposure to blood pathogens. If we're stuck by a needle or a sharp object, or we get blood or other potentially infectious materials into our eyes, nose, mouth, broken skins, the first and foremost thing that we need to do is flush the exposed area with water and clean with soap and water and disinfect if available. After that occurs, we would follow our agency's guidelines. However, FA Davis lays out that we immediately flush, we report the exposure to the supervisor or to your instructor. We seek immediate medical attention. We should consent to testing and follow-up treatment as advised. We complete an incident or injury report, and we would attend counseling sessions provided by the agency if needed. Remember, research shows that healthcare professionals too often fail to comply with guidelines for infection prevention, even the seemingly simple measures such as hand hygiene and standard precautions. So I hope all of you will do proper asepsis and infection prevention. Thank you.